Hello. We're here again. It's a very important topic, or very interesting topic again, or very interesting question, as you will hear it. And the big question is there a difference between COVID infection, and COVID injection? That's the question, no? Or what are the key differences or key similarities of the two? And it's very important to understand so that we can deal with it much better. As much as we want to say that this COVID is irrelevant already, but that's not true. So we're still here discussing, so many things about it. So um, that's going to be our question or topic for tonight. So, welcome to Dr. Villa Live and updates. And it's January 31st. So, welcome back. We are taking our freedom. Dr. Villa here, I'm back. So, the big question for tonight, or for today, not tonight, it depends on where you are. So, um, if it's good evening, like in Asia, and then good morning here in the US, I'm in Florida. And so, I'd like to discuss the differences and similarities of COVID infection and COVID injection. And by the way, we need to really start calling this as a COVID injection because this is not a vaccine, right? We should start calling it as it is. It's an inoculation, but not really a real vaccine. Just to give you a reminder, they had to change the definition of vaccine for them to be able to call it vaccine and for them to be able to get emergency use authorization at that What's time. The difference between COVID um, infection and COVID injection? Well, the difference is the first one is obviously the COVID infection, the port of entry or the way it enters the body is through the respiratory system. That this is a even though it's a highly modified virus, it's a respiratory virus. So the mode of entry is through your respiratory tract or through the nose or even through the mouth, and then the infection happens. So in infection, the COVID infection, well, just like the other viruses that goes through the nasal passages or respiratory tract, there's basically two major I would say stages. You have the viral stage and then you have the immune stage. If you remember, all of you, if you go back to when the pandemic was very acute, that's how we discuss and actually remember to understand how the virus should be dealt with. And the viral stage is you have the incubation period, and then the replication period, and then the patient gets sick, which is the start of the immune phase. So in the immune phase, that's already the time that the virus is actually doing a lot of immune activation, and the complication or whatever is the injury or the disease that it's going to do. Like at that time, everybody like really got so scared because the target was the lungs, and you create a lot of inflammation in the lungs. Then you're going to have a lot of swelling, and then the end result at that time was the resulting disease was respiratory failure because of ARDS, acute respiratory syndrome. And once the virus has done that, or the immune system has done that to the lungs, the chances of recovery are very, slim. And so it's not really the virus that's killing the patient during the immune stage, but it's actually the immune response, the overwhelming immune response. If you remember, you had the cytokine storm, no? So basically, it wasn't just the lungs, but it's actually affecting the entire body, different organ system. But the demise of the patient is basically related to the overwhelming respiratory failure. And so if the patient survives, then there's some recovery, but it's prolonged. Then the patient goes into the recovery phase, which again is affected by the immune response. The lungs will recover, but there is a fibrosis that follows, and then we learn that there is going to be the long COVID phase, which is a much more chronic stage, because the patient, even though recovering from the infection was completed, there's a complication in different organ system. And again, later on, we learned that there was a persistence of the spike protein, and even persistence of the actual virus that we know now is actually in the gut. The gut is a reservoir, and even the sinuses. Okay. And so that's one of the very basic mechanism how the long COVID is, created, or is the resulting condition. And the long COVID is very complicated, and it involves a lot of organ. It's a multi-organ system, dysfunction, and the patient is very symptomatic when it gets to that stage. It's the debilitating disease. So that's the infection, no? It's like when the virus gets into the body, into the system, that's the sequence of event. But that was the original variants, no? But the infection has evolved, and it got to the point that the virus was just staying up here in the upper respiratory tract. It doesn't go down to the lungs. So the lungs are actually spared, especially the current variants now. It doesn't go down to the lungs. And the sign and symptoms, or the disease that it creates, is actually very mild. But it depends on who is infected. Unfortunately, the vaccinated people have more symptoms right now, and we'll discuss that. So you have the viral phase, and you have the immune stage in the infection. What about the injection? So the injection is the mRNA injection. When somebody gets inoculated by the mRNA injection, COVID mRNA injection, you don't, you bypass the respiratory entry. There's no virus. So you have um, the uh, uh, the mRNA or the copy of the spike protein of the virus that they converted into, or they copied it into an mRNA. And then the mRNA goes into your body, goes everywhere, and it goes into cells, into the cells of your body, and it actually forces or trains your cell, any cell in the body, whether it's in the brain, in the heart, in the lungs, everywhere. Then your cells, your body starts manufacturing the spike protein, right? Whereas in the infection, the virus introduces the spike protein after like massive replication. Whereas in the injection, it is your body becomes the factory of the spike protein. And the spike protein is the basis of the disease. The resulting disease is the major mechanism by which the diseases are created in different organ systems is because of the presence of spike protein, whatever organ system we're talking about. Whether it's myocarditis, whether it's interstitial lung disease, whether it's encephalitis, whether it's hepatitis, any inflammation in any part of the body, the major mechanism or the major cause is the presence of the spike protein. You get that? So that's the difference. The injection goes directly into the immune phase. So the immune system processes it. It goes into the cell. The cells, your human cells, manufactures the spike protein, and it's being dealt with by your own immune system. And the sort of a sad part to this is even the immune cells are not spared. So it can get infiltrated by your mRNA injection, by the mRNA, and will suffer the same way as any other cells in the body. It does not discriminate. The mRNA injection will infiltrate, will go into any type of cells in the body. So is that clear now? The infection has the viral phase and the immune phase, whereas the injection goes directly into an immune phase. And so you can see once the spike protein is being produced by your body, by the immune cell, then that's where the problem begins. And any cell in your body that is actually producing the spike protein, or any cell in your body that has the spike protein, whether it's viral or infection, from infection, or from the vaccine, it will do exactly the same thing. The other difference is that this is what we see, like as a behavior, the injection or the mRNA inside the cell of inside the human cell, it sounds and it looks like it continuously produces the spike protein. So it's almost like it's a never-ending process of spike protein production. And why do I say that? Because clinically, I don't have the proof that that is happening, but just because of the clinical behavior, the spike protein antibody doesn't go down. That is not a behavior for wanting of a vaccine. Okay? If it's a real classic, or traditional vaccine, after the introduction of the vaccine, the spike, the antibody of the vaccine produced because of the vaccine, it will go up, it will peak, and then it goes down after a period of time. But this mRNA injection, I will tell you, we're already in the 6th year. So I have total 5 years information or data. The spike protein antibody doesn't go down, the level. The only thing is we don't have a spike protein direct testing available. We don't have the testing of the spike protein antigen. The only thing that we have is the testing of the spike protein antibody. But I think it's going to come out very soon. And so we can do the direct correlation. So the spike protein antibody will keep on being produced because the antigen, the spike protein, is like the stimulant, is there to stimulate the immune system to keep on producing. So now, for the sake of distinguishing the two, what disease syndromes are being produced by the infection and by the injection. So the infection is called long COVID, right? So just to make the distinction easier, so long COVID, so we're going to call the the injection like long vaccine, long COVID vaccine, or long mRNA injection. So basically, it's a post-COVID condition, and the other one is post-vaccination syndrome. So what are the signs and symptoms? I am going to tell you, at least from my experience, they're exactly the same. If you don't tell me, if the patient doesn't tell me that he is that the patient is vaccinated or just infected, and if you ask them in terms of the sign and symptoms, they are going to be exactly the same. And what are the most common sign and symptom? Fatigue is number one, the most common of them all. It ranges between, I don't know, 70 to 80% probably. If I look into the exact figure later on, I'm going to have that. But in my population, the senior population, I believe it's between 70 to 80% of the afflicted individuals, they have fatigue, shortness of, and the next is like, it depends on what organ system is affected. For the lungs, it's the shortness of breath and cough. For the heart, it's just when atrial fibrillation or cardiovascular hypertension is very common. And then if it is the gut, diarrhea, abdominal pain, nausea, vomiting. And for the neurologic, the neuropathy is, I think, number one. And then headaches and so on and so forth. So it depends on what organ system, but it's the same. To me, the disease syndrome or the spectrum of signs and symptoms is exactly the same. And what about, I just want to point out, to me, the clinical presentation of both in terms of what is the most common organ system affected. It's just me or my population that I serve, the most common organ system that is affected. And it's probably because also my practice, number one is the immune system is, for me, is the primary target. It doesn't matter what other organ system follows, whether it's the heart, the lungs, the brain, the nerves. There is always an underlying immune dysfunction. So there is a immunologic signature that you can actually identify. Um, with the paper that we're going to publish, I hope that we can really pinpoint that. But just to give you like a general idea or overall idea, the most common immunologic dysfunction that I see in my population of seniors, number one is the autoimmune. Uh, I think that um, I've seen them all, or probably not. Okay, again, it depends on what organ system is involved, but the most common autoimmune diseases that I see are lupus, rheumatoid, mixed connective tissue disease, scleroderma, autoimmune thyroiditis, autoimmune hepatitis, and um, autoimmune gastritis, and um, autoimmune. Oh, I said thyroid, right? And the most common actually is the thyroid and the liver. And so it's a very challenging, autoimmune diseases to treat. Oh, the other one is the APS, the antiphospholipid syndrome, which is closely related to the coagulation dysfunction or the formation of blood clots. And those are like today when I was seeing patient, I saw another APS or auto or antiphospholipid syndrome is a very bad case, and it needs a lot of intervention. That patient that I saw today. So, and again, to reiterate, all these diseases that I'm mentioning, autoimmune diseases I'm mentioning, you can see it in both the infection and injection. The only difference right now, as a preliminary conclusion, again, I think the infection is a little bit higher or has a little bit higher rate compared to the injection, but I could be wrong. And what else? The immune deficiency. I think I've been saying this all this time that there are two types of immune deficiency, that both the infection and injection um, are producing, and that is immune deficiency involving the production of your antibodies, and immune deficiency that is affecting directly your immune cells. And it could be both. And so that's very bad. Yeah. And just because the immune system becomes suppressed or depressed, then the surveillance system or mechanism of the immune system, surveillance system, like detecting cancer cells or detecting or infection or keeping the latent infection at bay, we lose that. The person who got infected or injected, you lose that. And this is, again, I've been saying over and over again that it's just a matter of time. It's not if. It is going to happen. And as a disclaimer, this is what I am seeing in my population. Whether it's not going to happen in young people, we need to do a further study or observation on that. And it's going to come. There is another issue that I just want to point out, the issue of shedding. And if anybody of you listening, and this is the first time that you're actually, hearing this shedding. So basically, shedding is you're actually you can give or you can transmit the spike protein or even the the mRNA, you and obviously the virus, you can transmit that, but the shedding is a different form of transmission or mode of transmission, because it's not just the respiratory tract, through respiration, and the um, the item or the entity that you're transmitting, whether it's the vaccine itself, the virus, or the spike protein, and even the antibody. Actually, you can transmit that to other people by shedding, and you do that through the saliva, and then breathing, and then through tears, bodily secretion. From sweat to vaginal discharge, secretion, or the semen, and what else? Through the blood. When you get transfusion, any bodily fluids that are produced can potentially a vehicle for shedding. And usually uh, the uh, um, the entity, as I said, virus, spike protein, antibody, and even the virus itself will be usually enclosed in an exosome. It's like little bubbles that you produced by the human cell, and they come out, and it's like a container. And then once it's inhaled, or through the skin or mucosa that it's getting in contact with, then it can gain access to your body and into the blood and stuff. And what is important here is, number one, it seems like this is only happening in the injected individual. There's no study um, available on the infection, but I can only assume that after the infection, if the patient is still um, having a large amount of spike protein, they can actually, go into the secretions. And so, but the study that was done, I believe that was in 2023, which was authored by several people, but obviously everybody knows Dr. McCullough. He was one of the authors, and the uh, one of the authors of that study or research paper on shedding. So our blood supply is an issue, is in question, whether it's contaminated by the spike protein. And if you transfuse it to somebody who's not vaccinated, or who didn't have the infection, that individual can potentially get sick from that transfusion. So any bodily fluids, okay? So that's another difference. As of now, only the vaccinated, or I should say the injected, are the only ones doing most of the shedding. What is the lesson there? That the disease syndrome on both infection and injection is very similar, including the symptomatologies and the signs, and both have post infection syndrome, and there is a post injection syndrome. So I think what I would like to tell everyone, that if you are symptomatic, or even not symptomatic, if you really want to know your status, you should get tested. And the first thing that what do you call it? The first thing that you have to check is the level of your antibodies. And depending on your sign and symptom, your doctor can go ahead and test you for autoimmune. And if you really insist because you don't feel good, then they can work you up for your the status of your immune system. And later on, I'll also discuss it here. What kind of test I do to work up or to do a workup on the infection, post-infection condition, and post-injection condition. Okay, I think that's all for today, and I enjoyed talking to you, and see you next time. Bye.